Now,
That's so good to hear.
on the opposite side of that, there is now a push to improve the quality of mastectomies for patients who don't want reconstruction. And everything has a catchphrase. I cannot remember it off the top of my head. But the basic idea was, bringing out awareness to what about people who want to go flat?
Yeah.
There are some people who it just doesn't fit their lifestyle to go through much and have reconstruction, or they've had reconstruction and no longer care to have a reconstruction. And so there's some nuance to making someone look pretty smooth and comfortable so they can put on a t-shirt and wear whatever they want and look appropriate, a bathing suit, a sports bra, whatever it happens to be. So even that aspect for the people who choose not to have reconstruction, there is attention being paid to the quality of those outcomes as well, so that people can have long-term quality, peace of mind, comfort with the way their own appearance is, and confidence with the people around them.
That's really amazing to hear. I have friends who have chosen to go flat after their cancer diagnosis and mastectomy. So it's great to hear that there are advances being made for women who make that choice for themselves.
Right. Yeah, we kind of want to, it's not just about choosing what we think is the best option. The best option is what's right for the individual. And it's, sort of our job and our responsibility to maximize that outcome, whatever they happen to choose.
Yeah. I love that. I imagine there's obviously a lot of talk that's ramped up perhaps over the last couple of years about potential complications with textured implants and concerns about implants. So if a woman has had breast reconstruction with implants, what do you tell your patients to look out for, or even to monitor after they've had reconstructive surgery to make sure that everything is looking good, feeling good, and when to call if something arises?
Yeah, good question, because the number one most important screening tool after breast cancer, with or without reconstruction, is still self-exam. It's a monthly self-exam is still important, even though you're not necessarily examining significant amounts of breast tissue. Most mastectomies are going to remove 90 to 99% of the breast tissue. Self-exam then becomes, is anything growing in that handful of cells that's left behind? Or, being cancer, it can recur despite not really being grossly left behind or fully treated with chemo and radiation after surgery. That sort of defines a tumor as a cancer versus a benign tumor, is its ability to recur. So what we look for, we're screening really for a couple of things. A problem around implant-based breast implant associated ALCL, which is anaplastic large cell lymphoma. It's a very scary sounding name. It's usually not a scary diagnosis, but it can be. There's a very wide spectrum of how that disease can present, but recurrent breast cancer as well. So self-exam on a monthly basis. People who are reconstructed can have a recurrence that occurs deep. Those usually present with a new onset of pain in the chest wall. There's a lot of reasons for chest wall pain after mastectomy, with or without reconstruction, and not dependent on the type of reconstruction. We could touch on that later if you want. So what we do is, anybody who has new onset pain, we evaluate with ultrasound, possibly an MRI, physical exam, of course. The things that we are looking out for is anybody who can feel a lump, whether it's in the skin or down around an implant or deep into a reconstruction, or new onset fluid collections. And I don't mean a little bit of swelling after a a big sports kind of day where it's gone the next day. But the breast implant associated ALCL can present as much as 80% of the time with a fluid collection. That fluid collection is not an ounce or so, it's a lot. So someone may call and say, I now have one C cup and one D cup breast, and it kind of happened suddenly. And that's something we're watching out for, because that's a sign that there could be a problem in that fluid. There's a very specific workup for it. It's pretty simple. We aspirate fluid, we send it off for cytology and pathology. The pathologists all know what to look for and evaluate it. There are other reasons for fluid collections or a late seroma, late meaning not in the first 3 months of the post-op time. So late seroma is not always a cancer. People can have very minor motion-based injuries. I've had a person hop up on a table to sit down. I've had people just wave their arms and then get swelling. So little things can cause it. And people can bleed into that space of their reconstruction as well, because it's scar tissue. And if it stretches in a strange way, it can tear a little bit and leak. So there are non-cancer reasons to have fluid around there. Probably a little bit of bleeding and physical trauma, probably the most common, because the cancer, thank goodness, is still very rare. So fluid collections, lumps, new onset pain in the chest wall, or anything that you can feel that feels out of the ordinary. We just look.
Yeah.
We just look at it and evaluate it.
Yeah. Yeah, that makes sense. So looking for any changes in shape, size, perhaps more so, new onset pain, things of that nature is good time to call your doctor.
Right. And sometimes we'll see somebody call with let us know that they feel like the shape of the breast reconstruction has changed. Or when they do a self-exam, they feel like the implant feels a little squishier than it used to. And those can be signs of implant failure or ruptured implant. And many of us have office-based ultrasound, and those who don't can usually get an ultrasound pretty readily and take a look and see if the implants have failed.
Yeah. Do you have any recommendations? I seem to recall you suggesting a particular method of doing self-exams in the shower with soap tends to help. Is that something you recommend to most of your patients?
Yeah, it really changes the way you can feel what's underneath the skin to have soap on the skin, and a little bit of firm pressure, so you're really feeling what's pushing the skin up against the deeper structures, so that you can feel if there's anything. So whether it's spokes of a wheel or a spiral, I don't think matters. Is whatever's you're comfortable with. When I examine people, I kind of go like spokes of a wheel, but self-exam is even better. I have had a patient present with a 2 millimeter cancer under her skin. Wow. It was literally no bigger than the tip of a slightly used sharpened pencil. And she came to me, she said, do you feel that? I said, I do feel that. I took that little thing out. I took something out the size of a pea, and it was a little cancer. Wow. And that little pea had a margin around it. I took out a pea, but that was bigger than the actual cancer. So self-exam really works. And just getting to know what you've had all along really matters. And so soap on the skin, laying down, standing up, they say to do both, at least do it in the shower. Yeah.
Yeah. That's really important for those of us who have been through this, to keep checking and making sure everything's feeling as we hope it should.
Right. And it kind of doesn't matter whether your original tumor was palpable or not. So even if you couldn't feel the original one, it was found on your mammogram or from some other finding, it doesn't mean that the next bump wouldn't be palpable. So don't give up on it. It's still a valuable tool.
Yeah. Yeah, that's really great for patients to know. I really appreciate you sharing all of this, and it's remarkable to hear 8 years down the road how some things are really similar and some things have evolved since I went through this myself with you.
Yeah.
So that's a beautiful thing that
Right.
we keep learning.
It is. There's been a lot of innovation. I mean, I think that breast reconstruction has gradually changed over my career. Uh, the focus is no longer just getting a bump there so that people look good in their clothes, but the focus is now preserve as much as possible normal tissue and shape and of course function so that people can feel as normal as possible when they're
Yeah.
done.
Yeah. That's wonderful. Any final thoughts? I so appreciate you sharing all of this. Any final thoughts on what helps your patients have the best possible outcome for them, short term or long term?
Well, I mean, I think it takes a lot of factors to come together to get success. Um, People need to have help at home. They need to live in a clean environment. They need to not be dealing with too much stress of managing their homes. And many of us don't want to lean on anybody. They don't want somebody to come and clean their home, and they don't want somebody to help get their kids to school and deal with routine things. But really, you have to create an environment that's conducive to healing. And that means people need to be okay with relying on support, okay with relying on people to help feed them, to get their nutritional supplements in, to motivate them to get up, to rub their legs when they're tired. And it takes a lot of support to get through it. I just recently asked a patient, who's going to help you through this? And she said, I have a roommate. I said, well, then you're going to have to call on me a lot
Mm,
because her roommate may be a great person, but they may not be equipped or have a relationship that can hold it all together for them.
yeah.
Certainly, a roommate's going to be good about getting some food to her and things like that, but you know, it can take a lot. And then we have found that the more factors we control, the better we get outcomes. If people sort of progress through things in an orderly way, we have decreased their discomfort. We've increased the speed with which they get better with and get back to more normal things. And I think that's a lot of evolution over the last decades.
It for sure is. And I, for one, am super grateful to have had you there because we both know that we were calling you a lot in my journey, and of course I had the support of my now husband to help me through. So it's really great to hear all of this, and sounds like there's this wonderful balance being struck with helping patients find the right balance of moving but not being too active, and supporting themselves with nutrition and good self-care as well as support from others. So really, really wonderful to hear what's happening in this space for patients who are going through a really tough time.
Yes.
Yeah. Well, thank you so much for making time to speak with us for Brave Day, for what you do for Brave, for what you do for breast cancer patients. And thank you from myself. So greatly appreciate it.
My pleasure.